Hi everyone, are we live? Okay. Yes, we are live. Hi everyone, good morning. Just one day left, right? In fact, 2 days. आज को मिला के 2 days हैं अपने पास. So all the best. I am Dr. Sonal Parihar teaching you Obs and Gynae on Unacademy. Okay. So I am an MBBS, MD and MRCOG from UK. I did my MD from BHU Varanasi and even MBBS, that is BHU. Then I'm a consultant gynecologist practicing in the private sector in my own hospital, Jodhpur. Endoscopic surgeon, colposcopist, infertility expert. Ask Your Gynecologist is my main channel, which is catering to the common people who like watching all the videos, and Dr. Sonal's tutorial is another one for the students. Okay, then Plus subscription is for Unacademy. In Unacademy you get so many tutors. उनके सारे lectures live and recorded, सारे exams, सारे quizzes, सारे question banks आपको Unacademy में मिलते हैं. That is plus. Iconic में आपको मिलता है Unacademy के साथ Prep Ladder. That is another app जो आपको help करता है prepare करने में. तो इतने सारे apps हैं, 2 apps आपको एक साथ मिल रहे हैं. So that is a beautiful subscription. Light यानी कि it is feather light like a feather. So you get MCQs and you get PYQs and you get all the grand quizzes. तो ये इस 3 तरह के सब्सक्रिप्शंस हैं. हर सब्सक्रिप्शन पे आपको दिखेगा 10% डिस्काउंट. ये सारे रेट्स 10% डिस्काउंट के बाद है. ये डिस्काउंट आपको कैसे मिलेगा? जब आप मेरा कोड लगाएंगे डॉक्टर सोनल कोड लगाएंगे तो इवन 300 रुपये की चीज़ में भी आपको 30 रुपीज़ का डिस्काउंट मिल जाएगा. यानी कि 10% डिस्काउंट इवन छोटे से छोटे सब्सक्रिप्शन पे भी अवेलेबल है. प्लस आपको मिलता है 2 मंथ से लेके 4 ईयर्स तक का. 4 ईयर्स इज़ फॉर द फर्स्ट ईयर स्टूडेंट्स और जो सेकेंड ईयर में उनके लिए 3 साल का. तो इस तरह से आप खरीद सकते हैं. आइकॉनिक 6 मंथ से 4 ईयर्स तक का है. लाइट इज फ्रॉम 2 months to 1 year. Okay, so this is how it goes. Auto daily practice papers are for the people who are for the students who are purchasing the plus class. Classes कुछ plus होती हैं, कुछ स्पेशल होती हैं. स्पेशल वाली फ्री होती है जो मैं डेली आजकल ले रही हूँ, मॉर्निंग इवनिंग आफ्टरनून में भी लेती हूँ, लेट इवनिंग भी लेती हूँ. और प्लस होती है जो कि पेड क्लासेस होती हैं जिसमें पूरा बैच बनता है. उसमें आप ऑटो डेली प्रैक्टिस पेपर्स को प्रैक्टिस कर सकते हो इन द ऐप. FMG के बच्चों के लिए गुड न्यूज़ है दैट वी आर कवरिंग द एंटायर कोर्स इन 1 month और ये बैच शुरू हो चुका है. पहले भी 2 महीने का बना था, 30 मार्च से 30 मई तक. ये नया बैच बना था, अभी खत्म हो जाएगा 27 को. यू कैन स्टिल अवेल. अगर आप रह गए हैं तो जस्ट कॉल ऑन द हेल्पलाइन नंबर 85 and 85. कॉल देम एंड आस्क देम कि अभी कैसे ज्वाइन करना है, सो दैट जो भी टाइम बचा है 4 जून से पहले आप इसको अवेल कर सकते हैं. प्लस टेस्ट कैलेंडर्स, दीज आर द पेड टेस्ट फॉर नेक्स्ट 2023 एंड FMG. आप ये फोटो खींच लो इसकी और पूछ लो कैसे इसको एनरोल करना है. 4 ईयर्स के लास्ट 4 ईयर्स के क्वेश्चन बैंक्स आप खरीद सकते हैं. MBBS फर्स्ट ईयर की जो स्टूडेंट्स हैं, एनाटॉमी, बायोकेम एंड फिजियोलॉजी, जब आपको रैगिंग खत्म हो जाए तो बच्चों आप ये कोड यूज़ करके 3 months और 6 months का सब्सक्रिप्शन ले सकते हो. अभी तो आप लोग बिजी होंगे, रैगिंग भी चल रही है, पढ़ना भी है, 6 months बाकी हैं. वाई डोंट यू जस्ट गो फॉर दिस सब्सक्रिप्शन 3 months का? इट इज़ वेरी गुड बिकॉज 3 महीने में आपको सिर्फ 4950 खर्च करना है एंड यू गेट बेसिक नॉलेज ऑफ ऑल द 3 subjects, एनाटॉमी, बायोकेम एंड फिजियोलॉजी. क्योंकि जो ट्यूटर पढ़ा रहा है वो कई बार समझ में नहीं आता है, सीनियर्स पढ़ने नहीं देते हैं. सो दिस इज द बेस्ट टाइम टू एक्चुअली परचेज इट. ठीक है, अभी मत खरीदो, एग्जाम के आसपास खरीद लेना. देन PYQs एंड रिविजन क्लासेस फॉर UPSC यूनियन पब्लिक सर्विसेज कमीशन. ये एग्जाम 2 पेपर्स में होता है. इसमें 5 सब्जेक्ट्स होते हैं. OBGY मैं पढ़ाऊंगी, देन डॉक्टर संजय पीडियाट्रिक्स, डॉक्टर दीपक सर्जरी, डॉक्टर संतोष मेडिसिन एंड डॉक्टर नेहा विल बी टेकिंग PSM क्लासेस स्टार्टिंग फ्रॉम द 23rd of May एंड आई एम देयर फ्रॉम द 25th of May. आई विल बी टेकिंग 45 hours यानी कि 45 घंटे मुझे मिले हैं. टोटल 190 आवर्स का रिवीजन है. 1.5 महीने का बैच है. आप लोगों को सब्सक्रिप्शन या तो 1 month का मिलेगा या 2 months का. आई वुड सजेस्ट यू शुड गो फॉर अ सब्सक्रिप्शन ऑफ 2 months, जिससे कि आपको 17 जुलाई का जो एग्जाम है तब तक का सब्सक्रिप्शन मिल जाएगा. सो यू कैन अवेल दिस और पूरे 2 महीने तक आपको सारे ट्यूटर्स मिलकर आपको रिविजन करा रहे हैं. और क्या चाहिए? एंड यू हैव टू यूज द कोड डॉक्टर सोनल. ठीक है, नाउ कमिंग टू द क्वेश्चंस वेयर वी लेफ्ट येस्टरडे. कल हमने काफ़ी क्वेश्चंस कर लिए थे. Yes, we were on this particular question. So how many people are watching? There are 17 people watching. Let's have the answer. Good morning, Dr. Himanshu. Thank you, Dr. Himanshu. So in heart disease, I want you to write the answer like this, 10, and then you go A, B, C, D. Okay, so this is how you have to answer, because there is a lag in YouTube, so it is very difficult to understand आप कौन सा question answer कर रहे हैं. So let's have this answer, guys. Question number 10. In heart disease, prophylactic forceps is applied at what station? These are a bit difficult questions. कल हमने करे थे स्पेशल क्लास में. You can go and attend that class. Special classes are free. You just have to go in and put my code Dr. Sonal, unlock the class and watch it. हमने कल काफ़ी MCQs करे थे and they were difficult. Okay, question number 10. Right. So we have good answers. That is +2 and that is the answer because prophylactic forceps को आप +2 +3 पे ही लगाते हैं. We only go for outlet. Okay, this is outlet forceps. ये वाली outlet है and this is low forceps. Okay, हम high या mid cavity forceps आजकल नहीं लगाते. So this is outlet and this is, अगर ये +3 लिखा होता तो भी सही होता. ठीक है. Forceps should not be used in twin delivery, hydrocephalus, post maturity या फिर after coming head of breech. Should not be used. Very simple. Okay, 11. Yes, very good. Everybody has actually prepared very well for the exam. Very good. So it is hydrocephalus. One of the criteria to be fulfilled before applying forceps is there should be no major CPD by clinical pelvimetry, and hydrocephalus is a cause of CPD, so you don't apply forceps. Okay, forceps delivery is done in all except question number 12. Again the same question. It is not done in which one? Mento posterior, DTA, after coming head, या फिर maternal heart disease. It is a PGI question, guys, so it will be more than one option. Okay, not necessarily more than one option, but generally there are more than one options. Okay, anybody else? We have one answer, two answers. 12B. I don't know Annie and Dr. Anju, are you answering 11 or B or 12? You have to write the question number. So the confusion is between this and this, right? इसमें तो हम लगाते ही हैं forceps. इन दोनों में से आपको लगता है दोनों होने चाहिए या फिर एक होना चाहिए? PGI के questions में कई बार multiple choice questions होते हैं. Yes, I know there's a confusion between A and B. So definitely it is definitely A तो है ही because mento posterior cannot deliver normally. It is like brow. Okay, mento posterior का जो mechanism होता है that does not deliver normally. DTA में they are saying it may be for, because they are not saying outlet forceps, it may be key lens, you're rotating the head. So maybe yes, because DTA में आप forceps से उसको rotate करके निकाल सकते हो. Sometimes even ventouse helps in rotation. Okay, so the answer is A. As discussed previously, forceps can be applied in all those conditions where vaginal delivery can be done and cesarean is not mandatory. In mento posterior, vaginal delivery is not possible. That is why we don't apply forceps. Okay, so they have not mentioned anything about DTA, but that is not the answer. Right. All of the following are true regarding forceps and vacuum delivery, except what is not true. Vacuum requires more clinical skills than forceps. Vacuum is preferred more in HIV patients than forceps. Forceps is more associated with fetal facial injury. Vacuum has more chances of formation of cephal hematoma. What is wrong? Dr. Anju, you are answering which question? Again, you are not writing the answer. You are not writing the question number. Mansoor, can you please write the question number? Okay, 13B, 13B, 13B. See, I told you yesterday what are the advantages of forceps. When you require more traction, when it is a really stuck up baby and you have to deliver quickly, there is fetal distress, then you apply forceps. The disadvantage is that it causes a lot of maternal injury and fetal facial injuries because it is like this. I showed you the forceps yesterday. It is going to grab the baby like this. So when you make it more tight, it is going to give injuries, especially if it's a mal-rotated head. You put a forceps like this, so it is going to give marks on the eyes. So it can lead to more of fetal facial injuries. Okay, so that is why this is true, fetal facial injuries. Vacuum is preferred in HIV patients because it is also true because it does not cause maternal injuries. Maternal injuries are not caused by a small vacuum. This small vacuum cup is just going to basically get applied on the fetal head. and this is just going to lead to more subgaleal hematomas and cephal hematomas. So this is also true. Vacuum is good when it is a non-rotated head. You can apply, you can do rotation. It does not cause a lot of maternal injuries. So that is why HIV patients में vacuum is better. So the only thing wrong is vacuum requires more clinical skills. It is the forceps which requires more clinical skills. Vacuum you just apply and you just have to take care that you are pulling in the right direction and the pressure is appropriate. Forceps, it needs proper application and proper locking of the forceps. Then you should know how to rotate, how to pull. It needs a lot of traction. So it is definitely more skillful. Okay. So the answer is 13A. Got it? It is not B. It is absolutely right. In HIV patients, we don't want the maternal injuries to happen. Genital injuries जितनी ज़्यादा होंगी उतना ज़्यादा feto-maternal hemorrhage होगा. Okay. You don't want that. Understood or not understood? Nobody said yes. Not understood? Okay. True statement about vacuum extraction of the baby. True statement about vacuum extraction of the baby. Thank you, Sirimisty. Sirimiseti. Nice name. True statement about vacuum extraction of the baby. It's a PGI question, more than one choice. I don't know whether you will have these kind of questions. INICT में हो गया होगा ना? इसमें more than one choice है. Just a hint I am giving you. Pressure is maintained between 5 to 8 kg per centimeter square. Done when the cervix is fully dilated. Center of cup. True बताना है. Center of cup should be placed 1 centimeter in front of posterior fontanelle. Cup rim should be placed 3 centimeter from the anterior fontanelle. So what is true? You remember the anterior fontanelle and the posterior fontanelle? Where is the point of flexion? Where do you apply the ventouse, the point of flexion? Okay, so 14D, I have one answer. Anybody else? D. I told you it is more than one option. Select one more option. I'm giving you a hint. It is more than, there are two answers which are right. Okay. B and D. You are absolutely right, Swaraj. It is B and D. Okay. It is not C. 1 centimeter in front of nahi hota. It is around 2 to 3 centimeter away from the posterior fontanelle. Flexion point is found along the sagittal suture 3 centimeters in front of posterior fontanelle and around 6 centimeters from the anterior fontanelle. So somebody would say why 3 centimeter? This should be around 6 and this is around 3 centimeter. So this is the point of flexion. Okay. But why option D is correct? Because the cup diameter ranges from 5 to 6 centimeters. So this is a point basically which is 3 centimeter in front of posterior and 6 centimeter behind the anterior. But when you are applying this cup, it is a big cup, right? So it will cover that particular point. So this cup rim will be around 3 centimeter away from the anterior fontanelle. So that is what they meant. Okay. Because cup diameter is between 5 to 6 centimeter, the cup rim lies 3 centimeter from the anterior fontanelle. Then what else was operative vaginal delivery? Vacuum and forceps are done when the cervix is fully dilated. So definitely B is correct. The pressure we discussed yesterday, we have to start with 2 kg per centimeter square, increase by every 1 centimeter, and the maximum is up to 8. Okay. Maximum is up to 5, I guess. Correct me if I'm wrong. Maximum is up to 5, I guess. So no, it is 0.2. So it is 0.2 we start with. It is 0.2 we start with. Then we increase with 0.1 and then we maintain it below up to maximum is up to 0.8. So the difference was point in the point. So 5 and 8 is very, very high. So it is B and D. All right. Cervical dilatation should be more than 6 centimeter. Yes, definitely in not completely dilated, not full dilated cervixes, sometimes ventouse can be applied. But because it is written done when cervix is fully dilated, that's absolutely true. We try to give instrumental deliveries when it is fully dilated. But when there is a comparison between vacuum and forceps, vacuum may be applied when it is a incompletely dilated cervix. There is a difference between incompletely dilated cervix and non-dilated cervix. So non-dilated is wrong. Incompletely dilated cervix, you can try ventouse. Okay. Yeah, 6 to 8 centimeters होना चाहिए minimum. All of the following statements are true for episiotomies except. All of the following statements are true for episiotomies except. So in medical science, it is like you need to know the practical values when you are in practice, but when you are a student, when you are given an exam, you have to go with the books. So yes, clinically 6 to 7 centimeter minimum dilatation is required for vacuum, but nobody would apply. Nobody would apply. You will go for a cesarean section if it is an undilated, not completely dilated cervix. Okay. All of the following statements are true for episiotomy except which one? Allows widening of birth canal, can be either midline or mediolateral. Involvement of anal sphincter is classified as third, fourth degree perineal tear. Midline episiotomies bleed less, they are easier to repair and heal more quickly. What is wrong? (15D). Okay, anybody else? C, A. So getting all mixed answers. ये सबको पता है B तो सही होती है. It is either midline or it is mediolateral. Okay, you will be surprised. It is A. Okay. So actually involvement of anal sphincter is classified as third, fourth degree of perineal tear. I thought this should be wrong. This should have been wrong because see, it is just third degree, right? Perineal tear, it is not fourth degree. Fourth degree is when you involve the rectum. So let's read the answer. Episiotomy, it is defined as a surgical incision made over the perineum and vulva during delivery to increase the diameter of the vulval outlet, not the whole of the birth canal. Okay, so they are just increasing the vulval outlet because you are cutting the soft tissue, the muscles, if they are tight. Okay, and to prevent perineal tear. So it is basically given to prevent perineal tear and to widen the vulval outlet. Thus episiotomy is a surgically given perineal tear of second degree. As discussed in the text, episiotomy can be either mediolateral or median. Although median episiotomy has more advantages, it has less bleeding, easier to repair, better to heal, but it can extend. The disadvantages, it can extend into the rectum. Okay. Commonly a right mediolateral is performed. Anal sphincter involvement is third degree. Perineal tears are dealt with. So they have not given why third and fourth degree is not wrong. I just feel that they should not have written fourth degree. Why did they write fourth degree? Anyway. So it is option number A. Difficult, no? Sometimes it's very difficult to justify the answer. I mean, according to me, it should have been, but actually the way they have written, no, involvement of anal sphincter is classified as third, fourth degree. So it looks like, yeah, after anal sphincter, it will become fourth degree once the rectal mucosa is involved. Anyway, okay. An episiotomy is to be performed in a primary gravida and labor. Which of these is an advantage? Let me read it. There is a typing error. Which one of these is an advantage of mediolateral episiotomy over midline episiotomy? Episiotomy is performed. Advantage of mediolateral over midline. ये तो अभी हमने पढ़ा है. Less chance of extension, can be repaired at ease. Fewer breakdown, less blood loss. ये तो पता है सबको. अभी just हमने पढ़ा है. 16. No, they bleed more. They bleed more. The mediolateral ones are bleeding more. In the midline, so obviously it is kind of bloodless because it is the raphe where all the muscles are joining. That's the posterior fossa. That's the anus. So midline bleeds less, heals better. More, it's easier to approximate also, to suture also, because everything is thin out there. When you cut here, it is, you might even cut the ischiorrectal fossa, and then that becomes a very bulky thing to repair. So the less chance of extension is the right answer, and we know that is why we give mediolateral. Okay, less chance of extension. Then the following is always an indication of cesarean section except. Always an indication except abruptio, untreated stage of 1B/CA cervix, active primary genital herpes, type 4 placenta previa. Except what? Always an indication of cesarean. Then the previous D option should also be wrong. Previous D option, which one? This one? Midline, no, this is true. Ah, yes, allows widening. Midline episiotomies, no, this is true, no? This is true. Midline episiotomies bleed less, they're easier to repair and heal more. So this is true. They are asking which one is wrong. So this one is wrong. According to me, this should have been wrong because they have written 4th degree. But the answer is allows widening of the birth canal. Okay. So this one is 17A and you are all right. You are absolutely correct. Abruptio is not a absolute indication for cesarean section. Most of the patients will go into labor by simple amniotomy, especially if the baby is dead, and if you think that the patient is having good contractions, the baby is not compromised, you can go for a normal delivery. Okay. An attempt at vaginal delivery is indicated if the degree of separation appears to be limited. Continuous fetal heart tracing is reassuring. When the placental separation is extensive or the fetus is dead, then you can think about other things. Fetus is dead, then definitely vaginal delivery. Fetus is getting compromised and extensive bleeding is there, then you go for cesarean. So it is not an absolute indication. Okay. Then coming to an absolute indication for LSCS in case of a heart disease. Coarctation of aorta, Eisenmenger syndrome, Epstein anomaly, pulmonary stenosis. Absolute indication. Looks like all of them, but you have to select one. Absolute indication. They are confusing because all of them are actually indications of cesarean, but now they are asking absolute, which one is the most lethal one. Nobody's answering A. It's actually A. It's coarctation of aorta. When the aorta is involved, then there are chances of this patient dying because the aorta might rupture and nobody can save her in there. Okay. Coarctation of aorta. Heart disease during pregnancy in itself is not an indication for cesarean. Cesarean in heart disease is done in cases where aorta is involved, like coarctation, aortic aneurysm, or aortopathy with aortic root more than 4 cm, or recent myocardial infarction, or if the patient is on warfarin therapy as discussed before. In coarctation, elective cesarean is preferred to minimize dissection associated with labor. So in coarctation of aorta, if she goes into labor, there will be dissection of the aorta, dissecting aneurysm. Okay, so that is the most dangerous one. Alright. Next, indication for classical cesarean section. PGI का question है. You can select more than one options. Tell me. Indication for classical cesarean section. So you're basically giving an incision here like this, not here. CS cervix, kyphoscoliosis previous to LSCS, HSV infection, contracted pelvis. ACD, D, B. Classical, why will you cut uterus in the upper segment? They are not saying indication for cesarean, they are saying indication for classical. Why will you go in the upper segment rather than the lower segment? Definitely previous to LSCS is not an indication, because previous to LSCS में already incision लग चुका है, तो go there only, no? Why C? So this is wrong. HSV, why? You are not going to deliver the patient vaginally, but you can give a normal cesarean section. Kyphoscoliosis, why? Kyphoscoliotic patient will have a spine which is deformed. The spine will be deformed. It will be kind of bent on one side. Kyphosis will be there. So why a classical cesarean? So the thing is, CS cervix is absolutely right. A, whoever is answering A is right. But no C, no B, no D. I'm confused with E, but they have said it is E also. So it is A and E. Okay, so definitely you will not cut in the upper segment. That is very, very dangerous, and it is a very bulky muscle to cut from the upper segment and remove the baby. It's much easier to cut the thin lower segment. So definitely not these. For contracted pelvis, they are saying severe contracted pelvis like osteomalacic or rachitic pelvis is a indication because the lower segment cannot be approached properly. Similarly, if there is a big fibroid in the lower segment, or there are dense adhesions, or CS cervix, repair of difficult and high VVF, that is vesicovaginal fistula, severe degree of placenta previa with engorged blood vessels, previous classical, already पहले classical हो चुका है, या फिर contemplating to have a live baby sometimes in postmortem section. When the lady is dead, you have to deliver the baby within 4 to 5 minutes before the baby also dies. In that case, classical cesarean section may be indicated. I don't know why. Just because you don't have to separate the bladder. I mean, she's already dead, so it will be easier to get the baby out in the classical cesarean section. That is what they are saying. Now, classical cesarean section is associated with maximum incidence of uterine rupture, 4 to 9%. Rupture can occur during pregnancy, even prior to the onset of labor. Site of rupture is definitely upper segment. CS cervix is definitely the answer. Contracted pelvis, because you cannot approach the lower segment because of extremely rachitic pelvis. Okay, so it is A and E. Yes, Dr. Anju, it is E also. Which of the following is not a contraindication of vaginal delivery after previous cesarean section? So, not a contraindication of VBAC. VBAC is vaginal birth after cesarean. Okay. Previous classical, no history of vaginal delivery in the past, breech presentation in previous pregnancy, puerperal infection in previous pregnancy. Not a contraindication for vaginal delivery. That's again a tricky question. Question number 20. It's AIMS ka question, so you just have to select one option. But I can think of 3 options here. Guys, not a contraindication. Okay. See, previous classical agar hua hai, she already has a classical scar, you will not give her a VBAC. So definitely this is not the answer. This is a definite contraindication. No history of vaginal delivery, according to them, this is not the answer, because according to them, no history of vaginal delivery is a contraindication. But they have not told you that kitni delivery hui hai pehle. Like for example, one previous LSCS, we try for VBAC. So I can't understand why this is not the answer. Puerperal infection in previous pregnancy, why will you not give her a VBAC? I don't understand. Their answer is breech presentation in previous pregnancy. So it's C for them. If it was a breech in the previous pregnancy and that is why she had a cesarean, you can go for a normal delivery, because this time if the baby is not breech and it's a head down baby, you can go for a normal delivery, fine. But why are they not giving her a VBAC when it was a like infection in the previous pregnancy or no history of vaginal delivery? I don't understand. Maybe puerperal infection in previous pregnancy, they are suspecting cervical dystocia, so don't give her a trial of labor. But very tricky question and there is no explanation. So yeah, it's 20C. Right, vaginal birth after cesarean, that is VBAC, is contraindicated. Okay, PGI question, guys. How many options do we have? Definitely more than one. Previous classical, suspected CPD, no vaginal birth previously, previous uterine rupture. So now they are basically contraindicating with their own answer. Yeah, maybe because they are seriously, maybe they are thinking the previous infection ki wajah se she might not be able to tolerate the vaginal delivery. She might have more chances of infection. I don't understand. Or maybe that infection led to major complications, so you can contemplate it led to VBAC or some fistulas or something. So you can give her an elective cesarean section rather than going for a normal delivery. Okay, 21ABD. Okay. 21W, what is W? Manzoor. So previous classical is definitely a contraindication. You will not go for a VBAC. Suspected CPD, yes, it's a previous cesarean and suspected CPD, no vaginal birth. Now previous uterine rupture bhi hoga, yes, definitely. She has ruptured the uterus. Why will you go for a VBAC? Now the question is, in the previous answer, when I was not happy with the answers, no vaginal birth, this one, they were saying it is a contraindication. Now they are not selecting this. So they are now contraindicating their own answer. So definitely no vaginal birth previously is not a contraindication for VBAC. You can give her a VBAC even though she never had a normal delivery. Okay. So VBAC can be done. So yes, ABD is the answer. Who said it? Damu, Monica. You are absolutely right. It is ABD. Okay. So C is definitely here. C should have also be a selection of answer. No history of vaginal delivery in the past is not a contraindication. Okay. So it's ABD. Yeah, that is what happens, you know. Like I have given so many exams when I was doing my PG and then for the medical exams, MBBS entry and then MRCOG. There were so many books and some questions were always there which will confuse you. So it all depends who is the examiner, what they are expecting from you, what options they are giving you. In a woman having a previous cesarean history, all of the following are indications of VBAC except, okay, same question again, except एम्स का क्वेश्चन है, सिंगल आंसर। ओपी पोजीशन है एंड यू विल गो फॉर अ वीबैक। फीटल डिस्ट्रेस है, वीबैक कराओगे। ब्रीच है, वीबैक कराओगे। मिड पेल्विक कॉन्ट्रैक्शन है, आप वीबैक कराओगे कि नहीं कराओगे। ऑल ऑफ द फॉलोइंग आर इंडिकेशंस एक्सेप्ट, इनमें से एक इंडिकेशन नहीं है वीबैक का। ओके, 22B and D. Okay, 2 answers. They all look like we shouldn't go for a VBAC. Why will you go for a VBAC in a breech presentation? Why will you do a VBAC in fetal distress unless she's on second stage and you put a forceps? OP position, again, it's a difficult delivery and you know it's OP, you have already diagnosed it. Okay, mid pelvic contraction to hai, definitely mid pelvic contraction. Actually only C might be an indication, ma'am. Actually, yes, sometimes if it is a good breach, frank breach coming down, but in a previous cesarean history, why will you do a VBAC for any of these cases? I mean, none of them is a clear-cut indication for VBAC. So all look like contraindications, but their answer is mid-pelvic contraction. All right. So how much time is left? Let me just check. 31 minutes over, so we'll just do one more question, okay? Trial of scar is contraindicated in all except. It is contraindicated, again VBAC, okay? Trial of scar is same as VBAC. So it is contraindicated in all. History of previous classical, history of previous cesarean due to contracted pelvis, previous 3 LSCS, previous history of LSCS, indication malpresentation. Very simple question, very simple answer. I like the options here because now you can easily select which is not a contraindication. ट्रेंडिंग वीडियोज मैम ओनली FMG के लिए सेशन ले लो। आई एम नॉट इन द FMG ग्रुप, सो मे बी नेक्स्ट मंथ इफ आई गेट दैट ग्रुप। आई एम इन द नीट PG ग्रुप, सो FMG की OBGY ट्यूटर अलग है। आई एम इन द नीट PG group and the UPSC group. So we will be starting UPSC from 25th of May. But if you want to learn from me, if you like my way of teaching, the course is same, guys. The course is same. It's just the level of questions may be different. And I'm sure आपका भी वही level रहने वाला है, क्योंकि नीट PG और FMG का सेम कोर्स चलता है, सिर्फ बैच अलग है और काफ़ी सारे ट्यूटर्स सेम है। बिकॉज आई हैव जॉइन लेट, मैं 16 मार्च से आई हूँ, इससे पहले से OBGY ऑलरेडी कोई पढ़ा रहा था। सो दे आर इन FMG, ओके? सो आई वोंट बी एबल टू टेक प्रॉपर FMG के क्वेश्चंस, बट यू कैन जस्ट go through the theory classes that I will be taking from the 25th of May. Subscribe to the UPSC batch and come there, okay? This is not complicated. See, all are definitely contraindicated. Previous classical, you will not do a trial of scar. Previous CS for contracted pelvis is a contraindication. Previous 3 LSCS, no way, you will not go for a normal delivery. So only this previous history of LSCS indication malpresentation. So this time you can go for a VBAC if it is a normal presentation. Okay. So see you all guys at 4:30 today. On one of the students' request, I will be taking menstrual cycle recap. Menstrual cycle, all about menstrual cycle, and if we get time we'll do the hormonal study also, just a recap of the hormonal, all the values and all, okay? And at 8 PM we will continue with MCQs and some instruments. Yesterday I did instruments class at 9 PM. We will be continuing with that class plus some MCQs which are left over, okay? Bye bye.